Hi, everyone. My name is Zoe Saldana, and I want to thank you so much for being a part of this conversation that I have been asked on behalf of Liberatum to have with Dr. Michelle Tom. My hope for this conversation is for it to be moving and deep and heartfelt so that we can discuss with humility and love and openness and curiosity topics that are of incredible urgent care and consideration so that we can come together as a united human nation, especially here in the United States, and figure out ways to help communities, organizations, and nations that are in desperate need of attention, of just equal and fair assistance. And I guess also there is a selfish takeaway is that we all learn something that we weren't taught in history before about the native lands of Navajo.
Michelle Thomas, Hi everyone, I am Dr. Michelle Tom. I am a Navajo person who is a family physician on the Navajo reservation on the southern region. I hope this conversation that having today makes an impact on the eventual funding and recognition of the Navajo people so that we are treated with just like anyone else in the United States, to have the equality in who we are as a people, and it be shown and seen and felt with people who hold positions in government so that policy can be changed. And so the health inequities of our people, not with just the Navajo people, but all tribes in the United States. And say that we are resilient and we are still here and that we are strong. And preserve every part of who we are as a people, in our culture, in our language, all the way down to the songs and drums of who we are when we arrived on Mother Earth. And this is what I hope for.
I thank you so much for making time that you do not have right now at this moment, just to have this conversation, to bring awareness to not only the tribal nation of the Navajo, the Dene, but also to update us all on just how COVID has been, how your tribal nation has been reacting to COVID-19, how you as a physician are viewing your people and your nation, and what you think is the call for action that we will need, obviously. But I just want to start by saying thank you and getting to know a little bit more about you, because you sound to me like an extraordinary person.
Well, I appreciate words, and thank you for hosting. It's amazing, and for Liberatum, it is such an honor to be on a platform such as this and to get the story of the Navajo people out there. And so it's just huge for us, myself as a Diné person, and for our nation and all the Native American tribes in the United States and North America, actually. So thank you for having me on.
Thank you. And I just want to start by just having a little bit of a history on you. I know that you grew up in the southern region of the Navajo Nation, and after your medical training, you returned home to practice general, family medicine. Mm-hmm. And now you've been transitioning and working in the ER rooms of two facilities right now, mm-hmm. simultaneously with all the COVID-19 patients that are arriving. And how are you?
I am, I can't downplay the mental, physical, and spiritual fatigue of this. And not this just myself, but for all of the fellow people who are are literally on front lines, the nurses who are taking care of the patients, the ER docs, urgent care, the hospitalists, the ICU nurses and docs. Like, it is something that I believe all of us have never really probably thought in, something like this in the United States, right? Because we're a first world country, we have the best healthcare. For it to become at this level for us right now, and it's hard. Initially you have all this energy, but now we're literally into 3 solid months, and it's not slowing down. And initially it was okay, but now it's like it's really mentally, physically, and spiritually draining, and doesn't seem like it's letting up. So I think there's a call for people to check on our first line workers. I feel myself that I'm a pretty strong individually, mentally and spiritually, but I have it come in waves. So that's how I'm doing. Overall, I can't say too much because I'm healthy. Yeah. I have great family and friends. So above all, I think I'm just blessed to be in this position now. And can't too much into much more than that. So
of course. How, I know that you're pulling 36-hour shifts, and what is it that you're witnessing right now as a doctor, as a first responder, that's happening in your tribal land? And because right now, what I was reading in the papers that we were sent is that the Native American territory has the highest per capita COVID infection rate in the U.S., surpassing New York and New Jersey. And that was just 3 weeks ago, when New York and New Jersey were in one of the highest, the states that had the highest rates. And now I'm witnessing California, going through that, in Texas now with this second spike. Is it spiking also in where you are?
I think for the first time, we as providers feel it, the surge. Maybe other parts of the country and you're in your second wave. But for us, we're still in the first. We're very much still in the first. I do 24-hour shifts on the weekends every Saturday since we've started back in April.
Wow.
And this Sunday, it was the facility was full. Mm-hmm. As myself, as a small, low acuity hospital, we had COVID and non-COVID wing, and we were full. We couldn't accept anybody else, which in a sense really mentally saddened me, because I knew anyone who else was coming in would have to travel an hour and a half by chopper if they needed acute care. Stabilize them in the ER with their ER docs, but as a hospitalist, I couldn't take anybody else. And now they'd have to travel an hour and a half to get possibly a needed treatment, or they now have to leave home. And once you're COVID positive, once you leave, no one else can enter your room. And now you've left home into somewhere else that no one knows you. I think that's hard for me to understand. Not just where I work, but all of the facilities on the Navajo Nation. How could you imagine yourself being in the hospital and you think you're home, but now that you have to leave?
You have to leave,
and no one else can see you.
And you mentioned that a lot of these people that are leaving the reservation to seek, they don't speak English; they only speak Navajo.
Yes. Some of we still are very strong in our language and our culture here on the Navajo reservation. And I myself have a lot of Navajo speaking only patients. And that's when it gets super hard. And any person in their own language, that feels home to them. That's who you are. That's what gives you strength, because you understand word differently versus the English language. Maybe it be a Spanish language or a French language. There's certain words that you need to hear to give you this strength. Mm-hmm. And if you're going to a facility and they don't speak Navajo and that's all you speak, then you're almost like you are essentially in a foreign land, getting cared for, and you don't get to see your family. How do you communicate at that point?
Yes.
And that's heartbreaking for me to understand or even comprehend that. I couldn't imagine.
When you said, I hear you. When you said that the both facilities that you are currently working at right now in urgent care and the emergency room, when they're overcrowded, can you explain to us how big are they?
Right now we have 2 facilities in our area. We don't have, we have the outpatient urgent care, where I go and when I need to go there to admit patients to the hospital. We have 2 ventilators there, probably about 6 beds, but it's an urgent care. It's not a true ER. Our only true ER is another partnered low acuity hospital, and they have about 10 beds there with 1 ER doctor in the day. It's very rarely that we have a nighttime ER doc. ER docs are in high demand right now, and right now we have 1 during the day. We'll have a physician assistant or a nurse practitioner who's kind of trained in that. And so, yeah, I see a lot of the patients when I'm going from the hospital, admitting them into the hospital. I'll go see them in urgent care and the ER.
So you say you have, what you mean, 10 ICU beds? Is that what you have?
No, just regular beds. Regular beds. We at our low acuity hospital do not have an ICU unit. We just have regular low acuity. So anyone who needs ICU care, no matter what, has to travel an hour and a half by chopper out. And right now with Arizona surging, we can call 1 number and we have to wait recently an hour or 2 before we get a call back for a bed, and that's usually in the Phoenix area.
How many patients are you turning down? Because you said you had to start turning down people because you guys are full. What is the amount of people that you're turning down in a day?
Well, I had admitted a COVID patient early in the morning, like Sunday, about 10. And I was able to keep them there because we had 1 bed left for the COVID ward. And as soon as I went down there to do the workup, the ER doc asked again, "Oh, we have another one for you." And, of course, I had to say, "No, you're going to have to transfer that next patient out." And I was busy on the floor the whole time, so I didn't get a chance to go back to the ER. But you could hear choppers. I would say I at least heard 3 choppers that day.
Oh.
If that I could hear of if I was paying attention.
I wanted to ask you, in your opinion, and also your experience being from Navajo Nation, what are the reasons that are attributing to the numbers being so high for COVID and in your lands?
It's, disease has, and in any disease, it's multifactorial. Ours stems to something even more. We know COVID is by touch, touching something, a surface area of the person, and transferring it to your mouth or your eyes, or you're breathing it in. We are a matriarch society by origin, and we're oral history by origin. And so with that comes a very strong community. And one of the many reasons why we've had this outbreak is we have a lot of people who live in one home, a multi-generational home. You have the grandmother, the auntie, the niece, the nephew, that all live in one household. And, I even had a family who lives in what we call our traditional housing or home is called Hawan. And it's basically a 1-room circular building that one family can live in. And so when you try to tell them to self-quarantine, how can they? How can they? They don't have separate rooms. Further, we don't have, running water, electricity for a large majority of the homes. There are some, but our infrastructure as a whole as a nation lacks that. So you tell people to stay home, but they have to leave for food. They have to leave for water. They have to leave to, do the laundry. So they expose themselves every time they leave their house. We don't have the luxury of having home deliveries for food or for packages. You have to literally trust someone to leave that home so that they're doing everything they can, that when they come back, they're not exposing the family unit. And that's what's happened. We see a lot of the younger people leave to do these things, but they end up being positive and bring it back to the household. So yeah. And when they're going for groceries and food, they have to go to border towns. We only have 13 grocery stores.
And it's important that you bring this up, because I have it here in my notes, and then obviously we'll talk about hospitals but your Navajo Nation spans parts of Arizona, New Mexico, and Utah. So right now we're saying that 10 years ago, for the 2010 census, there was a reported 173,000, Navajo citizens, right? And now we're assuming that's probably at least doubled. And for the amount of people, the amount of region that your nation sort of encompasses, you only have 13 grocery stores. Because it's literally the size of like West Virginia, right? The nation of Navajo. And to only have 13 supermarkets, or just markets where people have access to food and everybody has to sort of share those 13 markets, gives you an idea of just how long people have to travel to have access to food, and the amount of contact that you're having with people on a daily basis from farther territories within your nation. It's a lot, right?
Yeah, so that's kind of what we use as a term, as a food desert, right? With all the people now, the stay home order from the Navajo Nation, before they close, they have to run out, right? Because the 13 stores are not adequate enough. You'll never see, it's immensely rare that you'll find a hand sanitizer, antibacterial wipes, water, right? Gallons of water or packages of water. So then they end up having to leave and go to the border towns, places like Flagstaff or Gallup, Page, Arizona, anything surrounding. Then you end up having to go there. Well, the people there are also grabbing all these things. So it's even rare again to be able to get those things. And in these stores, you're allowed one item per household. Wow. You see these signs everywhere. So even if you want to stock up, now you have, you can only get that one package of water because that's only allowed. So how many times now do you have to go back if you have a house full of people and you've only allowed one person to go?
Wow.
So it's hard, and it's not nutritious as well, right? And we have some fast foods in the Navajo Nation on top of that, which isn't going to really help. So
you don't have access to, if 35% of your population does not have access to running water, then that also means that they don't have the ability to grow and to keep their own livestock, to grow their own farm. So that in a way, it's the resources are so scarce that it's just hard. It's just hard for self-sufficiency to be succeeded, correct? Especially now when there's a massive pandemic. And let's get to healthcare too, because I know that you studied abroad per se, even though you grew up in your in your land, in your tribal land. You went to the University of Arizona, where you played basketball, and there you studied microbiology, and then you moved to Florida, where you continued your medical studies, and then you did your residency in New York, in Southampton. And when did you decide to move back, and why?
Well, it was Arizona State University, so get the University of Arizona. Don't get too much. No, but actually, they do deserve credit, because the University of Arizona, I obtained my master's of public health degree from them. So you are correct. So it's only been, I would say, about a year and a half since I've been home. And to study abroad is truly what it felt like when I left the reservation, because I came from a matriarch society. I spoke Navajo. I saw people who looked like me, talked like me, same experience. And I remember leaving at the age of 18. And that's that's probably the only time I lived here after residency, is that it felt like that. You go into a matriarchal society, you go into a very white dominant profession of Western medicine. But the goal was always to try to study as far away from the reservation so that I could always project possibly what could come home, and that was infectious disease. That was seeing how I could see a streamline how things were coming and approaching to our doorstep. And so that's why, I got accepted to medical school in Arizona. I could have stayed in residency in Arizona, but I felt that the world really accumulated in like Florida, right? New York and New Jersey. And so no matter how hard it was, and I didn't know anyone in any of those states, and I spent years there, the sole purpose was to learn as much as I can, because it was immense in diversity, which I loved. I met so many amazing people, just living with them. I lived right by Little Haiti when I was in Miami. I loved it. and I lived in New York and Southampton. And yes, it was the Hamptons, but it was the people there during the non-peak time of the migrant workers and those who were really the caretakers of the land. The Shinnecock Nation that was literally a mile away from me, which is a tribal entity in Southampton. That was their homeland. And I was able to treat them. I was able to treat them as well as New Jersey. And was able to pick the brains of the attendings who went to like Penn State and to Harvard, because you can get as much book smart as you can, but to gain experience and knowledge from those who have been practicing medicine, to say, well, why did you pick that drug versus this drug? That's why I went. And diversity of different diseases and the people, to get the cultural experience, to know how people live. And I think when you find out how people live, we all have the same heart. We all have the same body. And I appreciated that the most, I think, of all my training, to see how beautiful the world is, and then gather what I could so I could bring it home. So there was something that approached our doorstep. I was familiar with it already.
How has your practice changed since you've been back? You were practicing, I would say, a good year before COVID kind of, came and swept us all. What are the major changes that you've seen from your practice a year and a half ago to now in this past 4 months?
It's drastically different. I went to family medicine to really build a relationship with the people. Having hands-on, I'm an osteopathic physician, and I like to gain a relationship. Well, how many kids do you have? You have any dogs? What do you like to do for fun? Because I think you gain a trust that way and a respect that way from the patients that you're having partnerships with. And really putting hands-on about doing a truly physical exam to feel out different diseases and how they're feeling. And that's different now. I can't have those long conversations anymore. We've just barely started to have clinic again, but it's still very different. It's still very almost hands-off, because we have a lot of asymptomatic carriers of COVID-19. So our visits are still 6 feet apart. I'm in the hospital, right? And I have my COVID patients, and they don't even know what I look like, because I have full PPE. How, as a family medicine doctor, that's the soul of what I wanted, and to spend time with them and get to know them. I don't have that anymore. They don't have that with me anymore. They're telling you these stories, but how can they, if they can't see, your facial expression. I think that's how we connect as people.
Yes.
Right? How do they know what I look like? Do they know that I'm smiling? Do they know like I'm giving a look of hope or understanding? They don't get to see that anymore. It's hard for both of us, the patient and for the doctor. It's different.
What has been the hardest for you right now to practice as a doctor? When it concerns like, yeah.
I think two major things is when it's an elder woman who speaks Navajo and she has to leave and she can't see any of her family. And when a patient's scared and they're asking you what else they can do and they don't want to leave. They don't want to be transferred out. They don't want to be intubated. And there's nothing you can really do. And then they're asking, oh, what can I do now? What can I do now? And it's like, I have no answers for them. That's the hardest. And I can't keep them because we don't have an ICU facility at our location.
Let's tap on that too. When it concerns the resources that you are lacking, what are those? Because when I spoke with you a couple of weeks ago, and I know this is very difficult for you, so I thank you so much for sharing with us. There's very little that we know out here about what is really going on in your tribal lands and why you as a doctor, you feel impotent to help. What are those factors? How can we help? What is it that you don't have today that you are in dire need of that I know will help you guys, when it comes to treating your patients?
We have acute needs like right away, and then we have the long-term goals. COVID-19 really brought to light in the front on stage about the inequities of health care funding that we don't receive from our federal government, right? It just expanded that, our health, like our water infrastructure or our food desert with inadequate food supply, our access to health care. We only have 6 inpatient facilities on the entire reservation. We only have 25 ICU beds. That's it. I mean, how did that happen? How does that happen? And one hospital in the city already has 25 beds.
25 ICU beds and 6,470 cases with 303 deaths so far, and only 25 ICU beds. It's unacceptable. It's unacceptable. I know that the US government has been facilitating these loans throughout the United States. Were any of these funds, granted for Native healthcare or for the Native government?
We do have funding. We have 2 branches of government that kind of helps with our Native people. And one goes through the tribal side, the tribal entity of the different branch of the government. And then there's another one that branches off the federal government for the Indian Health Service. And the funding primarily went to the tribal government. And, with every government, there's always delay of time in putting that money into use because of governments, approval, looking over, voting, things like that. I don't know if we got more allotted for the Indian Health Service, which is primarily the government entity that gets separate funding to build hospitals And over the course of many decades, for a while there, it never increased. And that was with each administration that came through. And that was where the government at that time could have built more hospitals for us, gave us bigger funding to hire specialists. You know, you can have as many ICU beds as you want, but if you're not paying specialists like intensivists or critical care or pulmonologists to take care of those patients, that's what you need. And even now, we only have 25 beds, and so
it's just bananas. You just inspired me. Like now, for me at least, the call for action is to encourage the Indian government to also just expedite these funds so that you guys immediately have what you need. 25 ICUs is just, it's unacceptable. Also, why haven't you received the assistance of like organizations like Doctors Without Borders?
They have been. They've gotten Doctors Without Borders. We also got the University of California, San Francisco. But again, it's the facilities, right? We don't have the facilities. We can get as many people in, but if you're only going to have so many beds with the infrastructure to care for those patients, that's where you're limited. You know, we can't just put like a bed there and say, oh, doc, do what you need. The doc needs everything, right? You need ventilators, you need in the intensive care unit nurses, you need the engineering to create an ICU room. And that takes time. That way, you know, time is of the essence. You know, you and me, if we're big in the big city, we get to the ER, you're worked up, you have imaging, you have everything done within the hour.
Yeah.
You know, you got everything stabilized. I can get you back on the ICU floor within 30 minutes. And on my way there, I'm calling the cardiologist. I'm calling the intensivist. Hey, this is what's on the imaging. This is what I see. And they're already up in the ICU room with one-to-one with an ICU nurse. We don't have to rerun anything. And getting intervention immediately saves lives. It dramatically decreases mortality and morbidity. But out here, if those 25 beds are used, now I'm going to have to call a facility. It's like takes an hour. It takes another hour to get the chopper there. It takes an hour and a half to get somewhere there. And then when you get to the ICU facility, you have to run all the labs again. And then the risk of just transferring to critical patients. You're changing partial pressures of oxygen in the air. They may or may not be intubated. What if it moves, you know, the tube moves, or the pressures of your body is such in a critical state is so vulnerable to change in your pressure. Now you have to put them in the air and change and move them all over the place. In residency, we used to have a group meeting with intensivists, myself and maybe another doctor. Okay, this person is a CT, and we're on the 4th floor. Do we move them? Should we move them, or should we wait till tomorrow? Just to go down the hallway in the elevator and get them down into radiology. We used to have meetings like that about how critical, is it worth it? And now it's just unmanageable that now I have no choice. We have to get them in the air and get them out of here. And that's the difference in a city versus being on the reservation. And I think that scares me the most, even with my immediate core family. What if it was my mom or my dad, you know, my brother or my sister? Why is it that we have to wait that long to get care like that? So yeah.
I hear you. I see you. I see you. If there's one message that you want us all to have, if there's one way that we can all help you, how is it? What is it?
Oh, I think with the movement of everybody, with Black Lives Matter, with you know, LGBTQI, marginalized people, is just to be seen and know about the inequities we've had for decades, and we're the first people of this land. and yet we lack the basic things, the access to healthcare. Voting is right, it's huge. About getting the right people in the right place to give us more funding. You know, there's not forms of so much genocide on our people since day one. And yet we're still here, and it gives me good pride and strength that, yeah, we're still here. We're very much alive. We're very strong. Is for the first time giving us a voice, backing candidates that it can help us get there, and bring equality for everyone. You know, we're not all equal until we are all equal. You know, as frontline workers, we've just want, like, sometimes I feel, even personally speaking, I feel, you know, almost to the point, maybe, you know, expendable. That you're like, well, you don't have to wear your mask here. You don't have to. You know, they're not, and they feel such pride. Well, I'm not going to wear a mask. It's my choice. And yes, it's my choice to be a doctor, yes. And I will do whatever I can, no matter who I encounter as a patient. I took the oath, and not even just the oath, it's just who I am, the kind of healer I want to be. But wearing a mask is just not just for you, but it's respect for others. It's respect for your family that you go home to. It's respect for your community. I mean, you are being part of a whole. It's not individualized. And so I think those are huge things for people that are now displaced from home. You know, I have not lived with my family for 3 months. Why do I have to do that? Why should I need to do that? You know, and then people walk around without masks, and they're being out in public, and they may not feel anything. And they may just be fine. And that happens very much. I mean, it happens very much, like a lot. But you could be a carrier and you take it home, and someone else gets sick. And yeah, the mortality may not be that high because they're estimating at 2%. You're sacrificing someone else's life for your own liberty. Wear a mask, and it's so simple. It's so simple.
So yeah, it's easy to think that you're not going to be a part of that 2%, and it's like, well, 2% is still a lot.
Yeah,
an unimaginable amount of lives to lose in our community, in our country. There's an organization that Liberatum will take us to, and I want you to tell us what is that organization, and how will this organization help?
So I, thankfully, with my great colleague and friend, Dr. Crystal Lee, she has a doctor in public health. We've known each other for such a long time. She put this organization together called United Natives. And basically it is a nonprofit organization where we try to bring awareness about Native American issues, not just the Navajo tribe, Diné tribe, but all tribes. And I asked if I could be a partner in that because I knew possibly that I could do more aside from being a doctor. As a frontline worker, that for a while there we were lacking so much PPE, right, on the reservation. Supply and demand were extreme highs for medical grade PPE. You know, we're competing against other major facilities in New York, now Texas, now all of Arizona, which are huge states, right? And then these are essential items that we need to do my job so that I stay protected, and not just me, but also protect the patient. You know, I see so many COVID patients when I'm doing car triage and urgent care or on the hospital floors that I have to protect them from me, and then they to me. You know, and eventually, you know, I don't want to take that chance for myself. I've had colleagues who've gotten sick. You know, we have other physicians that have died from COVID, very young. We had a physician who was 30 years old, and she's younger than I am, and she was intubated. She's fully healthy. Do I want to take that chance? No, I don't. So the organization initially is for frontline care workers. On the reservation where I gather donations, medical grade PPE and community-based PPE, so we can get it into the community as well. As a doctor, what do I do to stop the virus as best as I can for the community, for the public health awareness? So gathering monetary donations or collecting sanitizers, hand sanitizers, because we don't have running water. And so we really need that. Cloth masks. Also, face shields for people who are nursing homes, children's homes, shelters, people that more high need, because they're trying to care for the community and they're getting exposed to. And we've already done amazing things with nursing care centers on the reservation, where we've given them washable isolation gowns, face masks, goggles, things like that. So that's primary for the community. And then for frontline workers, giving N95s, gowns, face shields as well, to frontline workers like paramedics, EMTs, nurses, docs. So that's just to keep us safe, because we are very limited in our staff on the reservation in general. In all rural areas across the United States, it's like that. So, with the organization, that's what we're doing. And
the organization is called United Natives, and
United Natives.
We can send money. We can send also goods and foods and water and equipment, right?
Yes, absolutely. We never are going to turn away any donation, because it's going to be used, right? So water, of course. We've gotten canned foods, dry goods that we can obtain and then ship out. You know, we are United Natives. You know, I have patients for Apache and Hopi, and we're going to do like a big shipment tomorrow to the Hopi Nation, because we are united as one, doing these things. And so we want to reach as far and as wide as possible to get these things out there on the community, because it's a public health issue, right? I can only do so much when I'm in the room with the patient, but I can help prevent spread with hand sanitizers and water and cloth masks. You know, that's the purpose of trying to stop the virus wherever it may be.
Absolutely. Dr. Tom, I want to thank you. I want to thank you for just being so honest about what you're witnessing and what you're feeling. And thank you for making us accountable and making us a part. We can be we can be a part of the problem, or we can be a part of the solution. And this is important, because these are not things that we are being informed in our media here in the United States. We're not being informed on how the United Native lands of Navajo are dealing with COVID, and also dealing with just a massive health crisis that has been going on for far too long. I want to thank you so much for your time. And you have my cell phone, so you call me anytime.
You probably don't want me to do that. You probably, I'm just kidding. No, it's heavy. No. I appreciate your questions. I appreciate your time and sharing this space with me, for Liberatum, for making this happen. And I don't know much more to say, but just to say thank you.
If you would like to support communities in need, please click on the Liberatum link below, and it will direct you to the United Natives, which is the organization that Michelle Tom was talking about. Thank you so much for listening.